I request everybody to kindly stay back for a really enriching session on automated insulin delivery and advanced hybrid loop closed system technology. This is being conducted by the Medtronic teams, but we have wonderful esteemed speakers on updated technology. Please kindly stay back. We have the tea and some refreshments served on the back side of the hall only. Please stay back.
On behalf of Medtronic, I would like to welcome all of you for a very exciting workshop on automated insulin delivery. And for this, to moderate this workshop, we have Associate Professor Dr. Abhishek Kulkarni. He's a senior consultant in pediatric and adolescent endocrinology, department head and postdoctoral fellowship program director at SRCC Children's Hospital, Mumbai, and Sir H.N. Foundation Hospital, Mumbai. The first talk will be delivered by Dr. Ganesh Jewalikar. He's a principal consultant pediatric endocrinology at Max Super Speciality Hospital, Delhi, and he's a general secretary cum treasurer at ISPE. The second talk will be taken by Dr. Saurabh Uppal. He's a consultant director EndoKids Clinic, Jalandhar, Ludhiana, and Bhatinda. Followed by that, how to onboard will be taken by Dr. Tushar Godbole. He's a director, Harmony Health Hub, Nashik. He's also associate professor at Dr. Vasantrao Pawar Medical College, Nashik. Then the interesting way to interpret care link reports, that's an important topic, will be taken by Dr. Veena Nair. She's a consultant pediatric endo at Iris, Pangapara, Tiruvananthapuram, and she's also a consultant endocrinologist at Anantapuri Hospital and Research Institute, Trivandrum, Kerala. Then Dr. Santosh Oleti will tell us more about how is it really really impacting the children with diabetes, who is a consultant pediatric and adolescent endocrinologist at Karnataka Institute of Endocrinology and Research, Sri Shankara Cancer Hospital and Research Center, White Lotus Healthcare, Cloud9 Kids Hospital, and Fortis La Femme Hospital. And the last interesting session where we will be able to interact with the children and their parents who are actually using this therapy day in and day out. And this session will be moderated by Dr. Archana Dayalaria. She is a senior consultant pediatric endo at Institute of Child Health, Sir Gangaram Hospital, New Delhi. So with this, I would like to invite Dr. Abhishek Kulkarni to just set the tone, and then so I would request him to come in.
So, the future of management of children with type 1 diabetes has two probable arms, one being sensor-driven insulin and or counter-regulatory hormone delivery, and the other being stem or islet or probably stem cell grown islet transplantation with the need of removal of immunosuppression, which could probably be achieved by micro or macro encapsulation and or gene editing. But why we've gathered here for is to discuss the contemporary standard of care for children with established type 1 diabetes. And what we have to offer to them are advanced hybrid closed loop devices which not only deliver basal insulin in response to sensor glucose, but also provide automated correction boluses for the errors committed by the user. Now, why we call them hybrid closed loops is because there still remains an avenue for the user-initiated mealtime boluses with these devices. So the session is to sensitize all of us here with the appropriate use to optimize the glycemic targets for children with established type 1 diabetes. What do societies and guidelines say? That automated insulin delivery systems are strongly recommended for youth with diabetes, including offering them even early, even at diagnosis, depending on the patient's or the caregiver's needs and preferences. But for countries like ours, the caveat is the patients must possess resources and must have access to centers which would empower them to utilize these devices appropriately. Most of the Indian experience so far on automated insulin delivery stems from the use of Minimed 780G, and all of us would have a patient or two on the Omnipod 5 system, but we do not have structured data collation on the use of use of that device. So most of the data that is going to be presented in the session today is going to be related to the Minimed 780G system. With these words, I'd like to invite the first presenter of the day, Dr. Ganesh Jevlikar, to sensitize us on the basics of use of insulin pump. Over to you, Ganesh.
This is just going to be a quick revision. I think this is a pediatric endocrine audience, so we don't really need a lot of sensitization. So we'll be talking about few basic things, and then I have just a couple of case scenarios just to highlight some important clinical aspects. We know that continuous subcutaneous insulin infusion is continuously delivering a short or rapid-acting insulin with the help of a motorized pump. And the advantages of this are the programmable variable basal rates, which in the older models was manually performed, and in the newer models is being performed with the help of an algorithm. And there are advantages in terms of being able to take multiple boluses without having to have extra pricks. And with the older models, there was a feasibility of taking different kinds of boluses like square, dual, etc., which in the hybrid closed loop models is a standard insulin bolus. So insulin pump has a reservoir which, with the help of the motorized pump, is pumping insulin through this infusion cannula. With the in patch pumps, you won't be having this cannula. You directly have the infusion set, which with the help of a Teflon cannula is delivering insulin micro or mini kind of boluses in a continuous fashion, which works as a basal rate, and then the user initiates meal related or correction related boluses. It is inserted, the patch is inserted with the help of an inserter, and it looks somewhat like this. Now, conventional pump therapy was just a way of delivering insulin, and which further progressed in the form of availability of CGM and CGM giving inputs to the user to either just manually adjust insulin doses. And then in the sensor augmented pumps, there was a feature of low glucose suspend, where the insulin delivery was suspended at or before the occurrence of hypoglycemia, which is called as predictive low glucose suspend. But these pumps did not give extra insulin at the time during hyperglycemia, which is what is added feature in hybrid closed loop. Why the name hybrid? Because the boluses, the meal boluses or meal boluses are still user initiated. So the user has to announce carb intake. And in future, and probably we would be having fully automated insulin closed loop as well as multi-hormone closed loop pumps. I am not presenting a lot of theoretical data, but there is enough data largely from observational studies or registries which shows benefits of insulin therapy in terms of small or moderate reductions of HbA1c, but mainly in terms of reduction of nocturnal hypoglycemia, reduction of severe hypoglycemia or symptomatic hypoglycemia such as seizures or coma, and in the longer run, lower incidence of diabetic ketoacidosis. In India, we have hybrid closed loop pump therapy by Medtronic 780G, and the 720G is also one of the model which is available, which is priced at a lower price rate, but it is not a automated pump. There's Ipso pump. Some of our patients do import and use Omnipod and other pumps like Tandem T-Slim with Dexcom. The hybrid closed loop pump therapy is priced somewhere close to 500 to 600,000 rupees, whereas the older model or the conventional models are priced around 200 to 300,000 rupees. Many of the professional organizations say that insulin pump therapy is potentially beneficial for everybody who has type 1 diabetes, regardless of age. Does it mean that every single person should be pushed for insulin pump therapy? Probably no. There is still a role of clinician in deciding who would be a good candidate for pump therapy and who would not be. So take this example. This was using the older pumps though. So this is a 19-year-old with using insulin pump for and having a HbA1c of 12%. And when we, never went into ketoacidosis, but when we actually saw the data, he had not taken a single bolus over past many months. So he's just not taking boluses, only getting basal insulin. So that is just keeping him alive, but with a terrible cost. So we discussed all possible options. We gave him an option to go back on basal bolus. He said that, no, I will be good boy now. I will be doing everything correctly. I'll be sharing all the readings with you. And then he turned up 1.5 years later with a HbA1c of 15%. So this person probably was never a good candidate for insulin pump. So people who have unrealistic expectations thinking of pump, including the hybrid closed loop pump as a magic wand, underlying psychological conditions, poor adherence to even basic aspects of diabetes management, having difficult or discordant family circumstances, or having pre-existing severe reservations about the insulin pump therapy. There might be a difference of opinion between the child and the parents. The parent may be wanting pump, but the child absolutely hates having it. In that case also, you may not get good outcomes of insulin pump therapy. And obviously people who lack motivation to have good control. Let's go through a few basic pump settings. I'm going quickly through this because many of you are already aware about this. So total daily dose is something that we actually do not set in the pump, but it basically forms the basis for all your subsequent calculations. There are several methods by which you could calculate the pump total daily dose. So two of these are reduced injection dose method, which means that you calculate the pre-pump TDD and then you take 20 to 30% less of that dose. This is because typically because we are giving a continuous supply of insulin, the total dose requirement is less. There's a weight-based method where weight in kg into 0.5 units is the total daily dose of that particular person. You can average them and use the average of the two. The ISPAD and other societies recommend 10 to 20% reduction if there is a good glycemic control and few hypoglycemia. And if we are having frequent hypoglycemia, then the reduction is more. For somebody who does not have optimal control, maybe sometimes the reduction can be as less as 5%. So you have to use your judgment in what total reduction you are going to do. The other settings, so from this TDD, about 30 to 50%. So typically in younger toddlers or younger children, we use 30% as basal. In older, we use around 40%. In some, you may need up to 50%. So you multiply TDD by 0.3 or 0.4, and then you get your total basal insulin in the day. You divide that by 24 hours, and then you get hourly basal rates. You can set the manual setting of blood glucose basal rates is important even with HCl, because for first 48 to 72 hours, it's going to take into account those manual settings. And also during sicknesses or if there is a sensor failure, there's a default going back to manual mode. So that's a safety net. And therefore, checking and setting manual settings is also important, even with the advanced pump. For insulin carb ratio, there are several methods to calculate. The most popular method is the rule of 500. Then subsequently with CGM data and other studies, we found out that if the total daily dose insulin is less than 15 units or younger children, typically this 500 kind of turns out to be a wrong calculation. So for them, we use rule of 300. This 500 figures have come somewhere in 80s or 90s, initially from clinical sort of experience, and so subsequently validated using some statistical methods. Then insulin sensitivity factor is basically the reduction in the blood glucose that is achieved with 1 unit of insulin. In terms of we use milligram per deciliter, so we use rule of 1800 to calculate that, which means 1800 divided by total daily dose gives you the milligram per deciliter that is reduced by 1 unit of insulin. Target range, again, here individualization is important. I set typically target range of 100 for people having normal hypoglycemia awareness, and slightly higher up to 120 if there is a potential risk of hypoglycemia. Now, active insulin time is different from just a pharmacokinetic duration of insulin action. So active insulin time is actually more of a pharmacodynamic term. It is the number of hours the insulin is going to continue reducing your blood glucose. Uh, it used to be set at 4 hours or 5 hours previously. There are a few studies especially by the Ragnar Hanna's group, which show that probably for children it needs to be a little less. So in the older models of pump, in the conventional pump, we set it at around 3, sometimes at about 4 hours. In the hybrid closed loop pump therapy, the algorithm requires you to set it at 2 and between 2 to 2.5 hours, depending on the hypoglycemia risk. Just to revise these sample calculations for an example, for a 10-year-old boy weighing 40 kg on basal bolus treatment with a total daily dose of 32, with an A1C of 7.5%, which used to be considered as a good A1C back in maybe 2014-15. So we calculate total daily dose by reduced weight dose method. So multiply 32 into 0.8, that is, I have reduced by 20%, so 26 units. And by weight method, around 20 units. And I take average of these two, and which gives me around 23 units of total daily dose. The basal is total daily dose pump TDD into 0.4, that is about 9.2 units a day. Divide this by 24 hours, you get an hourly basal rate. Insulin carb ratio, I get by rule of 500 a ratio of 21, which I round up to 20, and a sensitivity factor of about 78, which I could round up to 75 or keep it 78. I set the blood glucose target as 100 to 100. The old bolus wizard feature requires you to set a range. So if you want a pre-meal target of 100, you set the range as 100 to 100 or 90 to 120. So it takes into consideration the average of that. And DIA of 3 hours. Now, this is the theoretical part. I just wanted to highlight few basic things in the form of a couple of case scenarios. So let's go through that. This is a 9-year-old girl with type 1 diabetes and hypothyroidism, compliant with treatment and follow-up. A1C is around 7.5 to 8. And she was initiated on pump for improving control. She met all the criteria that usually we used to check for pump. 6 months later, she has vomiting and abdominal pain. The parents think that because she had chicken biryani outside, she's having a reaction to that and she's having vomiting and abdominal pain because of that. So often these people, because they have been kind of under the diabetes care for some time, they over a period of time forget that vomiting means you need to check for ketones. So that knowledge has to be revised before you start somebody on insulin pump again. So this girl did have 5.2 millimoles per liter of beta hydroxybutyrate and ketoacidosis. And when we saw the pump, there was a air bubble in the reservoir, and the pump did not give any alarms. The pump continued to administer. There was no alarm of suspension of delivery or stopping of delivery. So these things can happen. So mind you that we need education on ketoacidosis prevention, recognition, when we are putting somebody on insulin pump therapy. This is another case, 15-year-old girl with type 1 diabetes of 5-year duration. She's using a 640G pump. These are her insulin doses. You can see that the basal percentage is 65%. So she's taking too much of a high basal. So often what happens is we do some settings initially, but in periodically follow-up, we just keep on doing minor adjustments and don't really look back at the whole picture. So this is what probably is causing her sugars to be very low in the night time, and she needs less basal. Another common problem that is happening is if you see these peaks followed by low sugars, this is a typical pattern suggesting to me that this person is not giving adequate time between the insulin bolus and the initiation or beginning of the food. So when we saw the bolus timings, she is actually taking a bolus after she has started eating. So this is a very common problem. So pre-meal bolusing is very important, and it has to be emphasized depending on the type of insulin that you're using, faster aspart or aspart. You have to give that much of a gap between the insulin bolus and initiation of the meal. So meal boluses have to be always before meals, even when you are using insulin pump. Probably third case, 16-year-old boy, poor A1C while using insulin pump. Weight is 78 kg. He's requiring 87 units of insulin in a day. This is his CGM, which shows that the sugars are all over the place. The sugars are very high. And estimated A1C did correlate with the laboratory HbA1c. And when we saw the injection sites, what we diagnosed was he had significant insulin injection site atrophy. Now, this is something which I, at least in my practice, see more commonly with insulin pump than with basal bolus therapy, that if they don't rotate sites, there is a higher chance of them getting lipoatrophy. So it is important for us to examine injection sites during the visits and to sensitize them about injection site rotation even while they are using insulin pump therapy. Last case is an 11-year-old girl with using a hybrid closed loop pump therapy, and she's just having terrible ongoing weight gain, and now she's also developing hyperandrogenic features. And if you see that after she comes back from school, some of these are just fake calves, but many of them are actually grazing kind of behavior. So using a pump does not give you a freedom of just going roaming free across your meal plate and just continuing to eat all the time. So the meal discipline or dietary management is also important when you are administering pump therapy. So I would like to end by saying that insulin pump is a physiological way of insulin replacement, but careful candidate selection is important. We have to set realistic expectations from insulin pump, and we have to pay attention to basics of diabetes management, such as injection site rotation, meal adjustments, exercise or sick day adjustments. Thank you so much.
Thank you. Thank you, Ganesh, for the presentation. I think we'll take questions at the end, discussion collectively. I'd now like to invite Dr. Saurabh Bhopal to discuss with us the need for automation. And while we do that, a quick comment. Ganesh rightly highlighted that setting appropriate manual basal rates is extremely important even while dealing with patients on automation, because the initial customization or individualization of insulin for the first 48 to 72 hours takes place with it. And during exits and sick days, the manual mode settings must mirror those provided by the algorithm. Over to you, Saurabh.
Good evening, everyone. Thank you for staying, and we'll try to make it worth it. So whenever we talk about advancement in technology, it happens because of two reasons. Either of the two reasons. One is you just want to improve something out of the human need for creating something better, like a new model of an automobile. Or second, you solve an unmet need, like an entirely new mode of transportation. So whether automated insulin delivery is either of the two, I'll leave you to decide. While my illustrious colleagues would discuss about technology, what I'll discuss about is clinical evidence, and then you decide whether we need automated insulin delivery or not. So what worries you more in your practice? Is it hypoglycemia or hyperglycemia? Now, if hypoglycemia worries you more, then we already have a low glucose suspend and a predictive low glucose suspend. And if hyperglycemia should worry you more, we should have advanced hybrid closed loop. We should have automatic insulin delivery. So let us see. Now, this is the landmark paper in 2020, which discussed for the first time, even children as young as 4 years old, that hyperglycemia affects brain. It leads to atrophy, especially in the thalamic regions. And many of us were there at the meeting in Athens, Greece, when this was discussed. And it served as changing our mindset and the way we practice diabetes. Now, what it told us that chronic hyperglycemia impairs spatial working memory. Now, whether chronic hypoglycemia or whether this replicates in acute hyperglycemia, this was a very elegant work where children with diabetes were put inside a functional MRI in acute hyperglycemia, and they were studied compared with children who did not have diabetes, and the findings were almost similar. Acute hyperglycemia, like for a small duration, also impairs working memory. So how it works is, somebody who is diabetic and is nervous, and you ask them to do something with like an exam, they won't do very well with it. So that is what it means. Now, if you look at brain using MRI spectroscopy and this very elegant marker, which is N-acetyl aspartyl glutamate, adjusted for creatinine in different brain regions, you can actually look at the brain mass. You can look at axonal mass, and as axonal mass, if the marker goes down, that means the neuronal density is going down. That means there's brain atrophy. Now, this is what it is. If you do MRSI in white matter in children, as prolonged hyperglycemia measured with increasing HbA1c causes a reduction of axonal mass. So, there's brain atrophy with hyperglycemia. Even 1 DKA at onset causes similar reduction in white matter as 10 years of bad glucose control. And if you have somebody who presented in DKA and has bad glucose control, as is there in many of our patients who come to us, initially it is the DKA, but later on the high HbA1c takes over, and these children are on a down slope of neuronal decline. So if we think कि अभी बच्चा है and it's a child, so you can allow for hyperglycemia, this is not right, because this child is going to suffer in the time to come. Now, the most conclusive evidence comes from the EDIC follow-up, the DCCT. Now, these are people who have diabetes who are 60 years old now, and they have diabetes for 40 years. And the findings of regional atrophy, most pronounced in thalamus, as has been shown in many studies over the last 3 or 4 years, is there. And this brain atrophy is linked to changes in cognition. And when you analyze the data, it is, if matched for all other factors, it is the hyperglycemia which is correlated to the brain atrophy. Now, this is very counterintuitive, because when these studies started, it was thought that hypoglycemia causes brain injury, brain atrophy. I'm not talking about severe hypoglycemia, but hypoglycemia did not come out to be the causative reason in any of the studies coming from the United States. And this was to the chagrin of people who were out to investigate. And on the other side, it was hyperglycemia, which was correlated with brain atrophy. Now, whether it is type 1 diabetes or it is glucose per se. Now, type 2 diabetes is way more than type 1. So, in fact, they found out earlier that it is the hyperglycemia, especially because now they have drugs which do not cause hypoglycemia at all. So, if you look at long-term data, the effects on the brain are same as in type 1 diabetes. So it is not the glycemic fluctuations in type 1 diabetes, it is actually the hyperglycemia, and the areas affected are the same. The parts of the brain and the brain function affected is the same. It's the visuospatial memory. Now, this again, if you look at mild cognitive impairment in adults with diabetes over a long term, large number of patients from the United States, what you look at, what comes out is adjusting everything else, all covariates, behavioral factors, medical conditions, physical function, diabetes treatment, environment, everything. You look at mild cognitive impairment, the elephant in the room comes out to be hyperglycemia. And surprisingly, it starts in pre-diabetes. You don't need to be having diabetes, because we all know in type 2 diabetes, there is a large segment of people who are already having pre-diabetes. They have dysglycemia. They don't have hyperglycemia. Mild cognitive impairment starts that early. Now, I showed you that people studied children or patients with diabetes and looked at their MRIs. This study from South Korea did it the other way. Can you look at an MRI and tell whether the patient has diabetes or not? The answer is yes, because the same brain areas are affected and the same pattern of brain function is there. So you can actually see the MRI and say, yes, this person has diabetes and this person does not have diabetes. And it is the small vessels in the subcortical region that get affected first, and then that's the theory of how the injury progresses. So now I think I've convinced you that elevated glucose is harmful. Now, this begets the question, okay, hyperglycemia causes brain damage. If you reverse hyperglycemia, if you make them normoglycemic, does the brain damage reverse? That is the big question that we need to answer, because all our patients are in front of us. This is a very cautious study from the United States. So randomized prospective study, people put on closed loop and people not on closed loop. And this is a very primitive closed loop. So time in range is 57%, which is very low when you compare to the closed loops that we have today. The findings are very clear that the cortical, the brain function improves, the brain structure improves as judged by cortical surface area, volumes, anisotropy, IQ scores, and functional brain activity. So you can actually give a better outcome if you have a better control of hyperglycemia. So why do we then allow higher mean glucose? Now, we all have been guilty of it. We're not pointing fingers. We sometimes think, and a lot of people think, in a small child, you can have an allowance for some hyperglycemia. Otherwise, they would get hypoglycemia. Now, what does the data show? Now, this is the data from the entire European registry for children using CGM. So, what comes out of it is severe hypoglycemia does not decrease with increasing the mean glucose. Can you see my pointer? I think no. Okay. So severe hypoglycemia does not decrease with increased mean glucose. So here you see as your mean glucose is increasing, your hypoglycemia is not reducing. In fact, it is increasing. It's the other way around. And what else is increasing? DKA. So by allowing hyperglycemia, you're not reducing hypoglycemia, but you're increasing DKA. So increasing mean glucose is harmful. Severe hypoglycemia does not increase with increasing time in range. So we think we tighter the control, more risk for severe hypoglycemia. No, the data says otherwise. It does not increase by increasing TIR. In fact, what reduces is DKA. The control gets better if you improve time in range. So increasing time in range is beneficial. And what is the problem? The variability. So your hypoglycemia will increase with increasing variability. So if you manage the variability, your severe hypos will decrease. And similarly for DKA. Now, why is AID a better treatment tool? Because it increases time in range, it decreases time below range, and it decreases time above range. Now, how do we know that? Now, many of you would remember this pre-COVID publication from the Type 1 exchange in US, where they actually showed that the control in American children was getting worse. It was very embarrassing for many people, but they did publish it. Now, the follow-up to that, so the red one is the previous data that was pre-COVID, and now things have improved. Now, what has changed over these few years? CGM use, yes, but it was already there. What has really changed in these children is the use of the closed loop in these children over the last few years. So as the adoption of the closed loop and the hybrid closed loop have increased, the control has become better, and that is the proof that this thing works. And this is the study which has been really talked about recently. It's an Italian study. It was cited by Dr. Khadikar in the morning also. So you see, as you graduate your technology from MDI and CGM to intermittent scanned CGM, then real-time CGM, then sensor-augmented pump, and to the hybrid closed loop, the green zone increases. The green zone, you all know, is time in range. So overall, 1.53-fold increase in time in range by usage of technology. Now, one thing additional in this, I want you to look at, there are two greens here. Usually we are used to seeing one green. There are two greens here. One is a light green and one is a dark green. Now, dark green is the time in tight range. Now, we already had a lot of problem understanding TIR. Now we have a new metric, but please believe me, it's a very important metric. I'll tell you why. Why should we bother about time in tight range? Because time in tight range, ladies and gentlemen, is true normoglycemia. Now, what is true normoglycemia, you would ask? Now, it's a range, obviously. Now, when you put CGM on healthy children, what you find out is most of the time is not spent between 70 and 180. Most of the time in normal children and people is spent between 70 and 140. So 70 and 180 is the traditional time in range, and 70 to 140 is the time in tight range. So the light green tells you normoglycemia plus dysglycemia. So that, I mean, the time spent in normoglycemia plus dysglycemia, and the dark green tells you the time spent in true normoglycemia. Now here you see, please pay attention to this. The area in orange and yellow that we do not want, because that's hyperglycemia, is almost constant. So as things improve, is decreasing. So things are improving, we are managing hyperglycemia, but the light green area is still in the high 20s. What is increasing is the dark green area. So as your time in range increases, what increases is the time in tight range. So the green zone is almost constant and the dark green zone is increasing. So when we saw a 1.53-fold increase in time in range with automation, the increase in time in tight range is 1.61-fold, which tells us that there's a higher relative increase in time in tight range. There's a very intuitive question. If nature spends so much effort, time and energy in maintaining blood glucose in a tight range, then it must be important. It must be important to keep glucose in a tight range. Otherwise, why would so much energy of the body in a normal person be spent on maintaining glucose normally? So this partially explains why things improve when you bring patients in tighter glucose control, because this is the glucose concentration which is which the brain is designed to live in the range of 70 to 140. So when you bring your data, bring your glucose readings between 70 and 140, the brain gains. So I would like to end my case with these conclusions. Elevated glucose is harmful, particularly for the brain. Allowing higher glucose values should be minimized in practice. True normoglycemia needs to be targeted, which is the time in tight range, and you'll be listening a lot about this metric in the years to come. And true normoglycemia can be targeted. And automatic insulin delivery is the answer to it, and hence I rest my case. Thank you.
Thank you, Saurabh. That was a fantastic presentation. So, two quick points. Data from the EDIC, as Saurabh mentioned, they looked at hyperglycemia, glycemic excursions or variability, and inherent individual risk. And researchers found that hyperglycemia followed by glycemic variability followed by inherent risks in descending order were found to be relating to thalamic atrophy and cognitive impairment. Secondly, the point that Saurabh highlighted, the pilot study actually set the tone for time in tight range. And you'll be happy to know that we've started to collect Indian data for time in tight range, because we define patients with readings more than 140 milligram per deciliter as dysglycemic or pre-diabetic. So with the availability of better technology, we should be targeting the time in tight range. I think the ATTD symposium this year will have a paper on time in tight range for children 12 and above, in conjunction with a group of endocrinologists who practice adult medicine. So, any questions, or maybe we take the questions later collectively? Okay, I'd now like to invite Dr. Vinay to speak about the algorithm per se that drives advanced hybrid closed loop devices. And while he gets his presentation set up, I'd like to let the audience know that the basic principle is the PID, principal, integral, and derivative. Just to simplify it, principle is how far is the mean glucose deviant from the desired target. Integral is how long has it been away from the desired target. And derivative is the rate of change of glucose towards the target. So if you keep these three things in mind, I think Vinay's talk will make a lot of sense to you.
Thank you. So I think it is very difficult to follow Dr. Saurabh. I think fantastic. Now he has filled with you so many questions and thinking. So I thought that, okay, what should I do? So I realized that we ask engineers to imagine. So we are imagining about why, and we ask engineers to imagine three things. We ask them to imagine that a drug that you give child every night could kill him with hypoglycemia. So the drug has very narrow therapeutic index. Now, second imagination we ask them is that, can you imagine that the drug you gave yesterday will not work today or won't work day after tomorrow? And the third imagination we ask them that the parents has to worry about the child every day till their life. So it's so difficult. So then they realize, oh my God, that's something that they can do. And you can see the picture from the beautiful mind where the mathematicians, decided, okay, not a difficult problem, we can solve. So let's see how did they look at it. So they decided, okay, they look at what is automated insulin delivery system. They look at, let's get the sensor glucose data that will measure the glucose. That will say that then they will use something called algorithms, as Dr. Abhishek has already mentioned, and they will use some mathematical models by looking at this data and calculate the doses of insulin that will be delivered. And this process will go on till we get the maximum time spent in the range of 70 to 180. Now, I will talk only about Medtronic 780G because in 15 minutes we'll try to do justice with this algorithm. So the algorithm was designed to basically enhance the user experience. The big challenge, as Dr. Ganesh has already mentioned, in its first presentation that there is so many challenges. Like, you start somebody on a pump and you don't get outcomes, then you also feel bad. Okay, what is it? So now what has automation should do is that it should give you outcomes that you should feel that, okay, great, I have changed one life. And the second thing was that minimizing false alerts. Then first, with the first generation of automated insulin delivery, there used to be so many exits. So now with this system, actually it gives you a lot of time, and it thinks that, okay, please take some action, and it will also tell you what to do, and then it minimizes exits. But the most important thing, the therapy outcome goal that the mathematicians were interested in, was that maximizing the time in range between 70 to 180. But that is dysglycemia, and in the next future versions we'll focus more on 70 to 140 as well. But then the other goals were lowering the A1C, reducing the hyperglycemia, and minimize hypoglycemia. So we are not only focusing on this, we are focusing on both sides, hypo as well as hyper. Now it is very difficult. Now you'll say, okay, how should we collect the data? How should we design the parameters? How should we design the equations? Should we do long clinical trials? It will take years to do. So what they decided, that they design millions of patient simulations, and with the use of AI they could do it, and they tested the parameters. They designed, okay, this much insulin to give, what will happen? Should I give it now? So the two questions that they were focusing on were how much to give and when to give. These were the two questions they were focusing on to design the solution. So let me tell you about the first thing they look at is focusing on auto basal. So what does auto basal does is that it gets the data from the sensor every 5 minutes. And just like you in the clinic, if I give you data, if the sugar is going high, you will increase the basal insulin. If the sugar is going low, you will decrease the insulin. Now imagine whatever you do in the clinic based on the data, somebody is doing it every 5 minutes. And that's what this system does, that based on the every 5 minutes of sensor glucose data, it changes the basal insulin. And it doesn't get tired, it works 24/7. Now another thing what it does is that when the sugar started going higher, then it realizes that we can't increase the basal insulin because basal insulin dose is very small, 1 unit per hour, 0.5 unit per hour. So it's very little insulin. So what it does is that when the sugar starts going above 120 milligram per deciliter and it has already reached max basal delivery, now you'll say, what is max basal delivery? So max basal delivery is decided by the algorithm every day at 12 o'clock in the midnight based on the last 3 to 6 days of insulin delivery data. So the max basal also changes every day. So when my sugar is rising, it first increases the basal insulin, and then once it reaches the max basal delivery, then it doesn't increase the basal anymore. It starts giving small autocorrection boluses and try to bring the sugar down. So this process goes on every day, every night to maintain the sugar values between 70 to 180. Now, when we look at the most of the hypoglycemias that occur because of bolus, we are very worried about bolus insulin. So if you see a data, if you review automated insulin delivery data reports and somebody's complaining of a lot of hypo, first to look for is bolus. So that is where when they were designing the solution to automate the bolus insulin, they first look at all the data collected, they look at the bolus calculator, and they found what is the bolus amount to give. Now these bolus calculators were used by our earlier versions of pump as well. So this was not a new. But what has new is that it made them safer by looking at what will be its impact in the next few hours if I give this boluses. So let's look at safe correction bolus. In your residency days, you get a lot of calls, the sugar is 400, sugar is 300, and you say, okay, based on these calculations, current glucose minus target glucose divided by ISF minus active insulin, give me this much unit. But then you don't go back to bed. You must be thinking, did I give more insulin? Did I give less insulin? Because that is the question that is going in your mind all time. Now imagine if somebody is telling you that whatever insulin you will give, if it's going to reduce the sugar in next 2 hours to less than 80, then it will reduce the dose by 25%. So this process goes on till it finds a safe correction bolus. So just show you an animation here. It has calculated the bolus amount by using the formula, but it doesn't give. It sees that what will be the impact of this insulin amount on the glucose. If it thinks that in next 2 hours it will reduce the glucose by 80, below 80, then it will reduce the bolus amount by 25%. Now this will go on till the safe correction bolus is found out, and that's what make it very powerful algorithm. Now you'll see how much time does it take to actually do. So this is just instantaneous calculations. So nobody has to even think about, okay, when will it find the right answer? Now let's look at meal. So it has something called meal detection, because children eat more than 3 times, 4 times, 6 times. And in that cases, it is very difficult for them to bolus for every meal. Now this algorithm has also a sub-component called meal detection technology, where based on the slope of sensor glucose rise and last 3 sensor glucose readings, it detects that this glucose rise is because of the meal. And then if it sees that the user has forgotten to take bolus, it starts giving small auto correction boluses to cover the meal. Now this is not fully perfected yet, but it can manage 2 to 3 meals in a day. Now second thing is that when you are calculating the meal bolus, there are 2 errors we make. Either the amount of carbs that we are estimating may be wrong, and when you are estimating carbs in a meal, there are 3 possibilities. Either you are perfect, either you are underestimating, and you are overestimating. Most of the time we underestimate the carb. The second thing where we go wrong is calculating the ISF. As Dr. Ganesh has already mentioned, these are calculations based on the empirical data. Now, how can the ISF be right? So that is another error that goes when you are calculating the meal bolus. Now, when you calculate the bolus with this, again, what does this algorithm does is that it doesn't give the bolus. It will see whether this bolus will cause the sugar less than 70 in next 4 hours. Now, what is the difference between the safe correction bolus and this? The horizon has become wider in terms of duration. And second thing is that it reduces the threshold from 80 to 70. So if it thinks that it is going to cause the sugar less than 70, it will reduce the bolus amount by 25% every time till it finds safe meal bolus. Now that is where they are trying to address the issue of hypo as well as hyper as well. So that is how the engineers designed this solution to help us to maximize the time in range. Now this is very interesting thing. Let's look at if somebody has no diabetes and he takes the meal, what will be his sugar distribution? And you can see this is how the normal distribution of sugar will look like. Now when you look at the hybrid closed loop, that was the first generation automated insulin delivery, it has 25% of the values above 180. Now that means it is not yet perfect closer to the physiology, but at least somewhere getting there. Now with the new advances, which is advanced hybrid closed loop, we have only 21.9% of the glucose values above 180. Now it doesn't mean every time the 21% will happen. When they look at large subset of data, this was what they found. Now you must be thinking, okay, that's great, but what is next? So that is where I just offer you a peek into the future. Now, where everybody wants to close the loop. Now there are many ways to close the loop. Either we can close the loop with biohormonal like insulin and glucagon, or we can continue to close the loop with the insulin. So now there is only one company which is trying to do with 2, which is Inreda, but all the others have abandoned it. So the engineers were thinking how now with the advanced hybrid closed loop, the person has to announce the meals. He has to announce the carbs, and then only they can take the meal boluses. Now the engineers thought that, okay, what if I can tie a Apple Watch and it has a clue app, and based on your hand movements, it can determine how much you are going to eat, and it will transmit that data to the pump saying that, okay, he is eating this many number of carbs. And this app is so beautiful that it can differentiate between eating with the chopsticks, eating with the spoon, or when you're drinking or something. So it is very smart. So what it does is that it basically was using this iWatch app to send the data to the mobile phone, and through that it was sending the data to the pump. Now on the top half of the graph, you can see that this is where the people should use advanced hybrid closed loop, where with every meal you have to announce it 15 minutes before the meal, and then when you will get the bolus, and you can see the beautiful time in range that is maintained around 100. Now at the bottom graph, if you focus, this is where they didn't announce the meal, they were just eating, and you can see how the clue was working. It was translating all the hand movements into the carb values, and the small insulin boluses were delivered. So that is how, and still you got 99%, okay, not 100%, but getting closer. But imagine the reduction in the burden. That is another important aspect of technology. It reduces the burden. You can achieve more than 70% time in the range with all the other modalities as well. But imagine, also focus on the burden of diabetes. Now we are all in the field of artificial intelligence and machine learning. So the second approach we are looking at is that no two algorithms are same. So how can we personalize the algorithm? So that is where the new concept called personalized closed loop, PCL. Now in this, what will happen is that based on the data, the digital twin will be created. Now this digital twin will create your data. When you go out, what do you eat? It will have geological tags as well. For example, if you go to McDonald's, what do you order? How much sugar is going to rise when you visit specific location. At the same time, it will have Clue app which will detect this meal detection and will start giving this insulin. So that is another way we are looking at closing the loop as well. So this is my last slide where we are saying you our objective is not only to maximize the time in range but also simplifying the therapy management. That is most important because we have to reduce the diabetes burden as well. So with the next few algorithm iterations, this will be able to handle the meals as well, so we don't have to announce the meals, and at the same time we will have smartphone control, so we don't have to carry big devices with these wires around and all. But it's a work going on, so I feel that in the few next, so I am a very optimist guy, so I always say next 2 years we will close the loop. So don't hold my collar if it doesn't, but that's it. So thank you very much.
Thank you. Thank you, Dr. Vinay. So Vinay has highlighted some points. Let me reiterate them. That the algorithm administers continuous basal insulin in response to sensor glucose. That's probably its best strength. The advanced hybrid closed loop devices offer the advantage of automated corrections. So that is basically an allowance for erroneous carbohydrate counting. And my colleagues here would agree. In the study that we performed across centers in India, we found 50% of the patients and close to 22% of the clinicians using technology were not counting carbohydrates correctly. It's a difficult exercise, and doing it consistently is next to impossible. So you need an algorithm to cover up for that deficit. And most importantly, this algorithm factors predicted future glucose, both while providing a prandial bolus as well as a correction bolus. It acts as a simulator to look for the predicted glucose in the ensuing 4 hours and also considers the slope of the previous CGM and the past insulin delivery. So it's a reasonably safe hands-on device. What Vinay didn't highlight, and I'd like to do that, is this algorithm is designed to take care of patients who need at least 8 units a day and not lesser. We have some data emanating now that it could work well with units as less as 5 per day, but so far, it is approved by the FDA for 8 units or more and to a maximum of 250 units per day, after which the algorithm falters. There's a huge lag time subsequently. And the FDA has approved it for use in children 7 and above, but anyone who utilizes more than 8 units a day is welcome to be put on the device if the treating team has the requisite expertise. And in countries like ours, when your patients are not educated enough to follow screen instructions or are unwilling to count carbohydrates or are unwilling to announce carbohydrates prior to a meal, then the clinician has to individually exercise his or her discretion to decide if the candidate is a right one for pump therapy. So I'll take this mic now for my presentation, and I'll be speaking on the Indian data till date in children and adolescents on automated insulin delivery systems. So we've collected more data than what I'm going to present, but we couldn't analyze it as well. So I'm going to stick to a section of the data that we've collected so far. And before I speak of the Indian data in pediatric and adolescent population, I'd like to highlight a couple of metrics and a few variables which determine the glycemic outcomes in children on automated insulin delivery systems. The most important one, the time in range, time above range, and the time below range. So the purpose of the algorithm is to ensure that the patient spends at least 70% of the day in the range in accordance to the international consensus goals of 70 to 180 milligram per deciliter. In times to come, we will probably be speaking of time in tight range, which is 70 to 150 40 milligrams per deciliter, but that will need to make that would require the algorithm to be more robust. The second measure of glycemic control on automated insulin delivery systems is the glucose management indicator. I've kept the formula right down on the left, but what it essentially means is the short-term glycemic control in technology-driven devices. So it's a short-term metric, a short-term equivalent of average glucose exposure in comparison to the glycosylated hemoglobin. And the important variables in automated insulin delivery which determine glycemic outcomes are the basal target that we provide to the algorithm. So while we say that the algorithm administers insulin continuously in response to glucose sensing, the intensiveness of basal insulin delivery is determined by the target that is provided. So the system allows you three default targets: 100, 110, 120. And I'll talk about the optimization of targets as I show you some data. However, the most important variable across studies is the time duration for which the patient uses the sensor and the smart guard. And that's obvious. The longer you use the system, the better is your glycemic control. So I'd lay emphasis first to the boxes on the right is the time that you spend with the device and technology, and you need a minimum of 85% usage of the sensor and the smart guard to achieve the international consensus goals. So first is the time of usage. Second is the basal target that you provide to the system. The third is the insulin carbohydrate ratio, which is the single most important variable for user initiated mealtime insulin delivery. And the more you optimize the insulin carbohydrate ratio, the more astute are your prandial boluses. And lastly, the active insulin time that Dr. Ganesh spoke about, it's basically the duration of insulin action that you are providing to the algorithm. And currently, based on validated literature, the duration of insulin action best suited as provision to the algorithm is close to 2 hours. In children where hypoglycemia is a concern and you would want your autocorrection boluses to be less intensive, you could increase it to 2.5 hours. But if you ask me what is the optimal active insulin time, or DIA, duration of insulin action, to be provided to the algorithm, currently the consensus is 2 hours. So before we move to the Indian setting, let's talk about what happened in the West initially, or what was the study model based on which we started to collect Indian data. Is over 100,000 users, data from over 100,000 users from Europe, Middle East and Africa was analyzed over a period of 3 years. And for our interest here is children and adolescents less than 15 years of age, close to 22,000 of them. And their mean time spent in the algorithm was 90%. And what we found on analysis, what was found on analysis was the mean time in range of this cohort was close to 70%. Now, this was again a very heterogeneous subset of patients. There was no standardization or provision of settings or no central supervision of use of technology by patients, and this was obviously retrospective analysis. So this was not a controlled study. This is data from the real world. So even in that setting, the algorithm and the system provided a mean TIR, time in range, of close to 70% with a glucose management indicator of around 7 in a large cohort of patients over a duration of 3 years. So the efficacy of the device and the sustainability of the efficacy was both demonstrated in the real world setting, close to 22,000 users. Now, when we fractionated the data while reading the paper, and we looked at patients who were actually using optimal settings, which was only 6% of the total cohort, you see the mean time in range went up to 76% without any change in the time spent in the hypoglycemic range. So that's the importance. And I often hear colleagues saying, will the system drive clinicians out of work? And I say, no, it's going to get us more work. The onus is on the clinician to train the patient and optimize the settings for best glycemic outcomes. So with provision of optimal settings, wherever the subset of patients was such that the provision of settings was supervised, you see the mean time in range went up by close to 7%, and the glucose management indicator dropped to 6.7% without any increase in the time spent in the hypoglycemic range. And this is data to demonstrate for over a year when the sensor glucose data was consistently analyzed month over month for a period of a year, the benefits were sustained. So looking at this data, we began collecting data on our patients, though for a shorter duration of a year and a half. And this is the first retrospective study we presented at the ATTD symposium, obviously in conjunction with other endocrinologists from across the country. The study mirrored the findings. The mean time in range of the group was close to 75%, and the time below range was well within the permissible limits of 4%. And if you look at the bright red line right at the bottom, that's the time spent in readings below 54 milligrams per deciliter, which must be less than 1%. So this subset of patients was very heterogeneous. There was no central supervision of provision of settings. We weren't sure what was the time duration that patients were using the sensor. This was retrospective analysis of the data collected, but we did find that the mean time in range was close to 75% in this group of patients. Then patients whose sensor glucose data we had access to, two of us pediatric endocrinologists contributed to this study, and we analyzed the sensor glucose data longitudinally over a period of 6 months. And we found that these benefits in the small subset of patients were sustainable over a time frame of 6 months. Now let me talk about a study that we presented at the ISPAD last year. This is a study exclusive to children and adolescents from India. So we retrospectively analyzed sensor glucose data from 160 children. Again, this study was retrospective, and there was no central provision of settings or central supervision of user behavior while the device and the system was being used. But pleasantly to our surprise, the mean time in range was close to 71%. What is, however, not depicted in this slide is the percentage of users who actually met the international consensus goals was only 57% in the beginning. So we got wiser by analyzing the data, and we found that the setting provisions and the user behavior across the country was probably not uniform and needed homogeneity. So we spoke to colleagues, we got it better, and then we are in process of analyzing the subset now, and the percentage of users now achieving the international consensus goals is close to 69%. So in the last 1.5 years, we've moved from 57% of our patients achieving the international consensus goals while using these systems to now close to 69%. And if you look at the Indian aspect of the slide, you'll be a bit surprised to see that only 3.6% of the patients in the beginning were actually provided the correct settings. Not that the Westerners were doing any better, only 5.9% of them had the appropriate settings, but we were a bit worse as compared to them. So this retrospective analysis right in the beginning taught us a few things, and from 3.6%, the number has significantly gone up. I'll need to speak to Vinay after the presentation to understand where we stand, but the number of centers now across India who provide the right settings has definitely gone up to double digits. So that's something very encouraging that we derive from retrospective analysis of our own data. And what did we understand were the factors that were associated with the best glycemic control metrics. So the first one was optimal time usage of the system. So the first take-home message is use the sensor, use the smart guard for at least 85% of the times. You cannot achieve the desired goals with lesser usage. And the other factors were those attributable to the algorithm. The algorithm that we have now is much better than the earlier 670 that Medtronic used to provide, with key features like sensor-driven basal rates, increased time of Umax and Umin insulin delivery. So the algorithm now continues to deliver insulin even above its maximum insulin delivery rate to get a control on the sugar before it decides to provide automated correction boluses. Another important feature of the new system is there is increased time now before the patient exits automation. In the earlier system, the 670G, exits were far more. So the patients would have to rely on a lot of manual usage time, which is much lesser in the 780G Minimed. In our set of patients, the exit was on an average 1 per week. So I'll show that in the next slide. The second important feature was optimization of the basal target. We began with 110 in most of our patients and then subsequently optimized it to 100 after we were sure that the time spent in the hypoglycemic range was lesser than what was recommended. And other user behaviors like announcing carbohydrates before the meal, administering the prandial dose before the meal, better carbohydrate counting skills, periodic revision of the insulin carbohydrate ratio by the treating clinician, and ongoing education and supervision were the other variables which were associated with better glycemic outcomes. Now, the rate at which the international consensus goals were achieved was also affected by the presence or absence of a structured initiation program. It, however, didn't make a difference to the long-term glycemic control at the end of the study. But patients who followed a structured initiation program of 2 days of system assessment, 5 days of system training, and at least 3 days of sensor augmented pump therapy before moving to automation achieved the goals faster than those who didn't go through this program. The other variable which is of importance, which one must look at, is the percentage of autocorrection boluses that the system delivers. More is the percentage of autocorrection boluses that the system delivers, higher is the avenue for improvement on the side of the patient and the treating clinician. So the autocorrection boluses must total to about lower 20%. In our study initially, the number was close to 26%. And as we got wiser analyzing the data and made correct changes to the system, the percentage now stands close to 21.5 or so. So though the algorithm allows you the liberty for autocorrection boluses, clinicians must attempt to keep the percentage to less than 25% or closer to the lower 20% of the total bolus insulin delivered. Some other observations that we found was the device worked on the principle of adaptation. The first improvement in time in range was seen by around 7 days. It continued to improve until the second month, after which the improvement plateaued for a particular set of settings allotted to the system. The exits in this system were close to 1 patient per week, far lesser than the earlier 670 as reported in the Minimed pivotal trial. Hypoglycemia and association with glucose variability were obviously age dependent. They were more in the younger children. And with intensive control, the percentage of time spent in the hypoglycemic range was higher, but still well within the permissible 4% range. We did not have a single patient presenting with diabetic ketoacidosis or severe hypoglycemia throughout the study period. There was obviously increased average scores of diabetes treatment satisfaction quotients. And another important thing that we observed was all of the earlier published data used patients making a transition from conventional insulin pump therapy to automated insulin delivery. While our study had a heterogeneous subset of patients who were also on multiple daily dose injection therapy. So we had a mixed bag of patients making a transition to automation rather than the earlier papers which only made a transition from conventional insulin pump therapy to automated insulin delivery. The limitations of our study were retrospective assessment and a small number of participants as compared to our colleagues in the West. We did not have any demographic data on the duration of diabetes mellitus. Neither did we know about the true baseline data of treatment modality of the users. There was lack of uniform structured initiation protocol initially, though now it's better. There was no centralized provision of settings for the users. There was no centralized supervision of carbohydrate counting skills or supervision of user behavior. The good points were, though, 90% of the users consented for analysis of data, eliminating bias of voluntary agreement on data sharing. So it's not that only people who did well shared their data, 90% of the users consented. And the system performs automatic daily downloads, which doesn't require us to chase the patients to upload and send their data. So these were two positives that technically that came out of the study. So my last take home slide is initial evidence from the real world setting. Now let me reiterate, all of this is from the real world setting. Data from controlled trials are obviously better, but all of our data is from the real world setting. Indicates that international consensus goals are easily attainable even amongst Indian users, and that too across an extremely heterogeneous subset of patients. Sustainability of attainment of glycemic metric goals is demonstrated in a significant subset of patients, though we do need a larger number and longer duration of use to reaffirm the same in accordance to our Western counterparts. Number of users attaining the goals can obviously be improved by ensuring adequate usage of the system, provision of optimal system settings, education at initiation, and ongoing continuous supervision of user behavior. Thank you very much, ladies and gentlemen. I'd now like to invite Dr. Tushar to take us through initiation and troubleshooting of the automated insulin delivery systems.
Thank you so much. And the previous speakers have already set the tone. They have convinced us that insulin pumps are not only helpful in preventing hypoglycemia, but also the long-term effects of hyperglycemia are also prevented. We have seen the fMRI images, and we hope that the insulin pump and the automated insulin delivery system changes the long-term scenario for children and young adults with type 1 diabetes. So in next 15 minutes or so, I'm going to take you through some practical aspects of onboarding. So the theory part we have already seen, and let's see how do we do it. So whenever we put any person on insulin pump, especially the automated insulin delivery, that is the advanced hybrid closed loop system, one has to understand that the effort taken by the clinician as well as the person wearing the pump is very minimal, and the technology part is the maximal. So what does the clinician has to offer to the patient is educate the person about carbohydrate ratio, set the active insulin time, and the auto basal targets are set by the clinician depending on the patient profile. The algorithm will decide the basal rate when the smart guard is on. The insulin sensitivity factor will keep changing as per the sugar readings, and the auto corrections will be delivered by the pump. So it makes our lives little bit easy. So how do we actually do it? So before onboarding, one has to understand that most of our patients are on multiple daily injections and we put them on pump. So initially we have to set all those parameters correctly. Dr. Ganesh has already deliberated upon the setting of the basal rates. So we have to reduce it by 20% of what it was previously on MDI. If the reduced total daily dose into 0.5, that is the basal recommended for the pump, if it comes more than 0.4 units per kilogram, then you can use the weight based formula. Generally adolescents will be requiring more of the basal because they have certain degree of insulin resistance, and children would be having around 0.2 into the body weight as the basal. And generally we set the basal as the basal rate divided by 24, that is the starting figure. Of course, many of the children will be requiring higher doses of basal insulin in the morning, and at night they'll be requiring less. So generally 2 or 3 settings are enough for the basal insulin. This is when we are putting the person from MDI to the pump. Please remember that first 48 hours of onboarding on this AID, the smart guard will not work, and that's why we have to have these settings of basal and bolus. So the bolus already have been spoken. The ICR will be 450 divided by total daily dose. If the child is very small, probably 300 or 350 per divided by total daily dose. Insulin sensitivity factor, to begin with, we set it at around 1800. But then when the smart guard is activated, the ISF becomes automatic. Blood glucose target is generally kept very tight at around 100 to 120. And the AIT, initially referred to as the active insulin time, now with automation we refer to it as the algorithm intervention time, where the boluses will be subtracted, or there will be reductions if there is insulin on board. So that is set anywhere between 2 to 3 hours for the manual mode. On automatic mode is generally 2 hours. When a person who is already a pump user switches to AID system, then the basal settings will be just copy pasted from the previous pump, and the bolus, if the person is already using a bolus wizard to deliver the insulin, then those settings will be copied to the new pump. But if the person is taking manual boluses on the previous pump, then we have to set all those parameters in the automatic pump, because the pump does not understand how much carbohydrate the person is going to eat. So we have to set the insulin to carb ratio and the insulin sensitivity factor and the range, because even if the person is on smart guard, by chance if the smart guard gets disconnected, the sensor gets disconnected, the insulin pump will go back to the manual mode, and there these settings are going to help us. So onboarding, when it happens, we have to set the CGM settings and we have to set the pump settings. So what are the initial settings for the CGM? The suspend below low is always on, because on manual mode we want the child to be safe, and it is supposed to shut down the insulin delivery as the child approaches towards 70. So it will be anywhere between plus 20 to plus 70 above the low threshold. So here in this case it will be somewhere between 90 to 140. So as the sugar starts dropping below 140, depending on the rate of fall of the sugar, the suspend below low will be activated, and the lower limit is by default at 70. The alert before low is generally off by default. It's the user discretion whether he or she wants to put it on. Alert on low is always on, because you want the alert while on manual mode, and alert on high is generally kept off, especially in earlier days, but you are supposed to activate after you educate the patient. Smart guard settings, although the smart guard will be activated after 48 hours, but the settings we have to do it right at the beginning, and you let the person wearing the pump understand what are the smart guard settings. So the auto basal rate, it is just like the cruise control for cars when you ride them on a highway. So the basal rate is set generally at 110 for children, because you want them to be away from hypoglycemia, and after 2 weeks or 4 weeks you reassess the risk of hypoglycemia, and then you can reduce the auto basal rate from 110 to 100. Auto corrections are kept on when the person is on smart guard, because that is the feature that we want to use. So technical focus is more on programming the pump, setting the basal rates, setting the carb ratio. You have to connect the glucometer with the pump, and the timing also has to be correct. We have burned fingers when the AM, PM, the date and time was not set correctly, and the sugars were going haywire. So we have had such instances. So please pay attention to the date and time in the glucometer as well as the pump. We have to pair the transmitter with the pump and start the sensor. This is the technical part. What is the educational focus before onboarding? The person has to understand how to bolus, how to suspend delivery when the sugars are going low, and when to resume the basal insulin delivery, especially when the manual mode is on. Carbohydrate counting up to a certain degree of accuracy. We all understand that we are not experts. Even the clinicians make errors while estimating the carbohydrates, but the carb counting up to a certain degree of expertise can be done by children above 10 or 12 years of age with assistance from their parents. Correction bolus, the person has to take correction bolus. The machine will prompt, but the person has to act upon those reminders. And of course, they have to acknowledge the reminders. That is the correction bolus when the sugar is high. They are supposed to read and respond to various pump messages. They should be able to change the sensor, and they should be able to set up the CareLink account. The CareLink account is there for the user as well as the provider, and hypo and hyper protocols should be educated to the child and the parents. These are the prerequisites before onboarding. So when you are activating the smart guard, which typically happens after 48 hours of putting the person on 780G, and those 48 hours are started from the midnight, and for those 48 hours the manual mode will be on. So technical focus here is again programming the smart guard settings, where we are supposed to just put the baseline sugar, the carbohydrate ratio, and the active insulin time. Educational focus here is how to change the infusion set again. Temp target. So this is very important. Although the automated insulin delivery takes care of the insulin delivery rate, there will be situations where the person wants a temporary target. For example, when there are sick days, the child is having loose motions and he is afraid of hypoglycemias during menstruation, during conditions like the child is going for a cricket match or some intensive exercises where he or she is afraid of hypoglycemias. These are the situations where the person will be putting the temp target, which is by default at 150 milligram per deciliter. Check need for exercise protocol, which is extremely important, and assess, understanding and address the issues and questions. And of course, patient responsibilities. AID system is automatic insulin delivery, but it does not have a brain of itself. It works on machine learning, but there are certain patient initiated events. For example, the person has to remember to take bolus prior to eating any carbohydrates, and secondly, the person has to ensure that the screen, the shield is on, the smart guard is on, by ensuring at least twice or thrice in a day that the smart guard is on, which is visible on the screen of the pump with a blue shield and the green circle. There was a study, this was the open label study published in 2022, if I remember, and where they had tested this protocol of shifting around 34 patients from MDI to the advanced closed loop system, where they use this protocol over 10 days. So the first step is to educate them with a 1.5 hours of session where they meet the eligibility criteria. The system is introduced, the patient expectations are understood by the clinician, and the responsibilities of the patient are taught to the patient. This happens in the first visit. The second visit, which is again for education, and there are 4 such visits happening in 4 days, where we teach them various parts of the insulin pump, including the sensor. You could do it in group if you have multiple patients being initiated on the closed loop hybrid system, and they are supposed to learn what is the smart guard. And in third step, we start the sensor augmented system, and 3 days observation period is given, and by the end of 9 to 10 days the patient is ready to take responsibility of that advanced hybrid closed loop system pump, that is the 780G pump. But it is often not practical for us to have spend 10 days with patient for all practical reasons. Our patients travel from great distances, and it's not practical for them to stay with us for 10 days. So you can devise your own protocol for your own setup. So if the person is being shifted from the MDI to the 780G, you have to go through all steps because it's a totally new system for a person using MDI. If the person is already using a basic pump and is going on to sensor augmented pump, especially the 780G, then you can skip the some part of the training. But whereas if the person is using a pump like 640G, which is already sensor augmented pump, but without the auto basals, then it becomes very easy for the person to shift to the new pump. So the duration, the training period will entirely depend on the patient's education level and whether you are switching the person from MDI to pump or pump to pump. Can we really simplify these protocols for our own clinics, and how do we do that? So there was a study again. All of us struggle with carbohydrate counting, even the doctors. And it is often said that if you need a good postprandial control, you have to learn the carbohydrate counting. But this study particularly compared two regimens of carbohydrate counting. One was the flexible meal management versus the fixed meal management. So what was compared and how was it done? So this study, the aim was to assess the contribution of precise carbohydrate counting to the glycemic control in comparison to the simplified meal announced scheme. So the idea is the person should be able to deliver bolus before taking the carbohydrate containing meal, and there has to be some carbohydrate counting that happens before the bolus is initiated. So these were teenage boys and girls between 13 and 18, type 1 diabetes children, and they were on previously the multiple daily injections. The primary endpoints were the number of children reaching the time in range and what was the difference between two groups with HbA1c. And the safety endpoints were DKA and severe hypoglycemic events. So the flexible meal management involved precise carb counting, and the fixed meal involved categorizing those meals into regular, large, and small snack. And these were the basic characteristics. And you can see if you are estimating the carbs like a large meal, small meal, or a snack, even then up to 73% of time in range can be easily achieved. Whereas if you are doing meticulous carbohydrate counting, you can achieve 80% of the time in range. So 73% is not bad. It's at par with the international guideline of 70% TIR. And the HbA1c reduction was almost similar. There was no difference whether you do a rough estimate of the carbs versus the accurate ones. Follow-up visits, we have to ensure every 2 weekly. Initially you have to assess and you have to see whether the time in range is achieved. The GMI, that is the estimated HbA1c is achieved, and you are supposed to look at the time in range, above range and below range. If all these parameters are achieved, you just continue with the same settings. Dr. Abhishek has already told us about the auto boluses. They should be as low as possible, preferably below 20 to 25%. So manual mode, you are all aware, you have been using pumps, but the best practice is to evaluate the manual mode settings for 1 to 2 weeks after starting the SmartGuard, because you learn from the SmartGuard report and you have to change those settings on manual, because when the SmartGuard is not working, the pump goes automatically on the manual mode. So I think I'm coming to the end of my presentation. You all will be provided with the quick reference guide system. It's very easy. It's just a 1-page summary which helps you in onboarding. So that's it. Thank you.
Thank you, Tushar. So I'd like to invite Dr. Veena Nair next to help us analyze the CareLink reports and act on them. While she gets her presentation ready, a few highlights from Tushar's presentation is the importance of having appropriate manual mode settings, especially during exits and sick days, in addition to the individualization of insulin delivery pattern for the first 48 to 72 hours. One important highlight, always tell your patients to keep the setting of suspend at low on. Do not be conservative and ask them to keep the settings at suspend before low on. Trust the algorithm. Third, as Tushar highlighted, we like to begin with a basal target of 110 and though not completely but partially validated in children with time below ranges of less than 2.5%, we could then move it to 100 milligram per deciliter. And lastly, a bone of contention, the uh, the provision of fixed meal carbs. So Petrovsky et al. Did that study in a group of Qataris children, very homogeneous ethnic Qataris with fixed meal patterns of fish and rice for major meals and kubus and labne for breakfast. I'm not sure if that would be a great idea for the heterogeneous type of population that we have, but for a small set of population, it makes things simple. Over to you, Veena, for your presentation.
Thank you. I'll start from where Dr. Tushar has left. So we have started the patient on, initiated the patient on pump. Most of the time when we start patients on 780G, particularly the automated pump, both the clinician and the patient sometime feels that both are relieved of each other. The clinician feels that now, okay, the patient, the sub patient and the pump will be leading the life now on. And the patient feels that he doesn't need the help of doctor nowadays because pump will take care of his diabetes. So the next 15 minutes, we'll see that that's not true. The clinician and the patient has to be in continuous link so as to optimize the glucose control through so many adjustments, for which it's important to have a CareLink account and a report. So CareLink report, CareLink is, as we know, is a web-based software from Medtronic, which will analyze data from the device, that is a pump, the CGM, as well as a glucometer, and presents these data in different formats so that we can utilize the data for informed decision making, for fine tuning of the pump settings for better glycemic control and overall diabetes management. So this CareLink provides us different data in different formats, like assessment and progress report, weekly report, meal bolus bizarre report, daily review report, device settings report, adherence report, as well as logbook report, and many more. So now we'll see, these are all like metric laden reports, and we'll see in next few slides how we can crack each and every portion of this report. The first one is the assessment and progress report. So if we look closely, this assessment and progress report enables us to get the data of a particular time frame. We can choose the particular time frame as well as compare with a previous time frame. So we can compare actually two different time frame data to see for the progress or the improvement in the blood sugar glucose control. The data which is shown in blue color is the most recent selected data, that is in the past 2 weeks most often. And the data B, the orange color data, is the previous data range to see any progress in the therapy outcome. So the next one to look in the report is this colorful self-explanatory bar diagram. If you see in detail, this has been covered by the previous speakers and multiple presentations. So what this shows is how is the glycemic control. We know that the ultimate aim of Minimed 780G is to maintain the blood glucose in the target range or the tight target range between 70 to 180 or more precisely in 70 to 140 range. So as per the international guidelines, the time in range should be more than 70% of the time blood glucose is expected to remain in 70 to 180 range, and the time spent in hyperglycemia should be less than 25%, or severe glycemia should be less than 5%, or the hypoglycemic times, that is time below 70, should be less than 4%, or severe hypoglycemia should be less than 1%. So in this representative bar diagram, we can see that the patient's time in range has improved from 70%, some 70% to 73%, and there is a reduction in the time spent in hyperglycemia, that is more than 180 degrees. That is severe hyperglycemia has reduced from more than from 4% to less than 1% without any hypoglycemic episodes. So there is definitely an improvement in the glycemic control between the two time frames. So the next part is the statistics. In the statistics, there are so many metrics which will show you how is the blood glucose monitored as well as controlled, which includes the percentage of smart guard use, the percentage of sensor use. Only if the sensor is connected to the pump, then the smart guard function works. So ideally, the smart guard as well as sensor should be used more than 85% for the best results. Then the another key metric which is equivalent to or similar to the HbA1c is the glucose management indicator, which we'll be discussing the next slide in detail. Then there is a coefficient of variation which reflects the glycemic excursions, so the glucose variabilities. And then there are metrics which will show you the quality control index, like number of calibrations given to the pump per day. And then you have the metrics related to the insulin delivery as well as the operational functions of the pump, like total daily dose, the bolus dose, the percentage of bolus, auto basal, auto correction boluses, what is the percentage of auto correction boluses from the total dose, set and reservoir change frequencies, the number of carbs entered per day or the carb announced each day before meals, the active insulin time setting. So these are the statistical data which we can see from this report. So if we look at these patients' report, we can see that the patient was using the smart guard option on 100% of times, with sensor uses 96%. The average glucose is almost similar, remaining around 156 milligram per deciliter. The glucose management indicator is 7%, which is in the recommended range. The coefficient of variation of glucose, that is like glucose variability, is it was 29.8, that is 30% in the previous time frame, while it improved to 26.95%. Ideally, the coefficient of variation should be less than 36% if the blood glucose is stable. The total daily, the average blood glucose is already, the glucometer value is 159. The patient was giving at least 2 to 3 calibrations glucometer values for calibration. The total daily dose, you can see it reduced from the previous time frame, that is 40 units to 34 units. You can see that the bolus amount, he was not giving adequate boluses in the previous time frame. Only 33%, that is only 13 units, that is 33% of the total daily dose he was using as bolus. So but you can see the basal auto basal was 17 units, which is 48%. The pump had to give there was more burden on the pump to give auto correction boluses because the patient was not bolusing adequately in the previous one. But subsequently, when he was announcing the carbohydrates, see, he have number of meals per day, carb announcements, it was 0.4 in the previous time frame, while now he is announcing carbs more frequently. I mean, he is doing it correct in terms of carbohydrate inputs, so that the pump could give appropriate meal bolus using the meal bolus wizard, and the burden on the pump has reduced. So there is reduction in the total daily dose of insulin use, and there is improvement in the glycemic control. And more about the glucose management indicator. We know that it is an approximate value of the lab measured HbA1c. It is calculated based on an updated formula, and it replaces the estimated A1c on CareLink reports. And the importance is that this metric is aligned across all the CGM manufacturers, so it is a reliable indicator. It is calculations is depending upon the unit of blood glucose we follow, the calculation is different. If we use sensor glucose in millimoles per liter, we get the glucose management indicator in millimoles per mole, and if we are using in milligrams per deciliter, we will get it in percentage. So this is ideal recommended GMI is around 7%. In case of controlled blood sugars. So let us see what is coefficient of variation. Coefficient of variation is a measure of glycemic variability. Standard deviation is also a measure of variability, but coefficient of variation is a better indicator of glycemic variability. We'll see how it is. It is calculated based on the in relation to the mean blood glucose. That is, coefficient of variation is equal to standard deviation divided by mean blood sensor glucose. Why should we need a different indicator for glucose variability? it is seen that the percentage CV is better correlates with the relative risk of hypoglycemia compared to standard deviation. And if the coefficient of variation is less than 36%, it means that the glucose is relatively stable. While if it is more than 36%, it means that the glucose is unstable. The glucose control is unstable. So from this simple example, you can see that there are two mean glucose values. One is 180 milligram per deciliter and another is 110 milligram per deciliter. The standard deviation, this particular patient has having glucose excursions, the standard deviation is 50 in both cases, but you can see that the coefficient of variation is different. In the 180 milligram per deciliter mean glucose, the coefficient of variation is 27.7, which is less than 36, and it shows a stable glucose, and there is lower risk of hypoglycemias. While in those one with 110 milligram per deciliter, you can see the coefficient of variation is 45.4%, which is more than 36, and that means that there is higher risk for hypoglycemias. Now next is the percentage profile, that the graph, when you see in detail, you can see this is a percentile comparison, and this represents all the sensor glucose readings day and night for that particular time period. The blue band represents the recent time recording, and the orange one represents the previous time frame. So wherever the bandwidth is less, when there is a narrow bandwidth, that means that the glucose variability is less, it is maintaining in a narrow range. While wherever the bandwidth is more, it means that the glucose has wide excursions, ups and downs are more. And the extremes of tracings indicates the glucose variabilities. Then the black dotted line, which is running through the middle of the blue band, is the average sensor glucose for the latest period. It will show only the latest time frame. Okay, now next indicator or next metrics to analyze is a smart guard exits. We know that only if the sensor is connected to the pump, then the smart guard works. Only when the smart guard works, the pump will function in the automatic mode. So there are occasions where the smart guard gets switched off automatically, or because of some mistakes or from the actions of the user. Let us see what are these reasons. The smart guard exits like in case of the disabled by the user, or the sensor has expired and it is not replaced in time. The calibration, there is no the user is not giving enough of calibration data to the pump. The blood glucose, the smart guard requires additional blood glucose for its review and better functioning, and that is, if that is not being provided, it can exit out of the function. The smart guard is not getting sensor values from the CGM, and there is a prolonged suspend. The patient has suspended it for a particular reason and then he forgot to switch it on. In case of frequent exits of smart guard, that could be prevented by the user, and we have to find out what is the reason and counsel him how to improve the use in future. This is very important that for automated delivery, the smart guard has to be on. Now, next one is the weekly report. This looks little crowded, and if we see the next slide, you can see in the weekly report, in a particular week, all the values of per day, or all 7 days, we can see in this particular graph. And if we see in detail, it shows this is the glucose tracings, and if you see the green color band, that is the time in target range which we expect the glucose values to fall. And you can see this the pink band is the auto basal, and you can see in between there are blue spikes, which are the meal related boluses which the pump gives depending upon the carb announced by the user before the meals or during the meals. And the carbs announced is in the orange boxes. If the patient puts more number of carbs, more than one carb amount in less than 3 hour duration, the pump will club all the carbs together, and then it will be seen as single value, but it shows in the bracket how many times, in how many fractions the carb was announced. Similarly, you can see in the blue bubbles, you can see the correction boluses which are given by the pump, and if the pump gives multiple corrections in more than one boluses in less than 3 hours, then that will be clubbed together as one single value, and it will be given in the bracket or like number of fractions. And you can see small blue notches below the line that are the auto correction boluses, while the upright bars are, the blue bars are the meal bolus delivered by the pump. And then if you can see, I don't know whether it is clear, see here, sometimes you can see here there is a gray background shadow which represents the active insulin time, so that the pump, while giving a correction bolus, it will take into account the bolus is previously given and the active insulin time sets, which is set in the pump, and so that it can reduce the bolus doses to prevent stacking of insulin and subsequent hypoglycemia. And next metric is the meal bolus wizard. It will show all the meal glucoses particular time period during the time frame. So basically in the pump settings, initially we have to set the meal timings. Like for example, in the breakfast we have between 6 a.m. to 8 a.m. So all the meals announced in between this time will be shown in this meal bolus wizard. And the right side of the this report is kept blank, so that if we take a printout, we can identify the problems and then we can write the suggestions and give it to the patient. We'll see this meal bolus in detail, meal bolus wizard. You can see this is the dinner bolus. So it will show the blood glucose values 1 hour before the meal, that is pre-bolus, pre-meal time, until 3 hours post meal. So the glucose values will be seen this time. So here you can see in the lunch bolus, we can identify certain problems. Here, the post-meal blood sugars are not controlled. They are still in the higher range. That means the user was not giving the bolus before the meals. He was using it during the meals or after the meals. So if he gives the boluses before the meals, it can effectively control the post-meal blood sugars. Then there is a daily view report which will give a detailed insight of the effect of carbohydrate intake, exercise, etc. And this is a daily review reports. And you can see this is a device setting report where actually it will have all the ideally or in initial cases, this setting report will have the initial settings which we have set while the pump was onboarded, and unless the patient has changed the settings. And many times after reviewing the record, the patient might need some changes in the device settings, like the manual or basal levels, the insulin carbohydrate ratio, the active insulin time, etc. may need modification if the blood glucose is not in the personalized recommended ranges. So this will show the basal rates in the manual board, the general bolus wizard settings, preset bolus doses, preset temporary basals. All this is in the manual mode which we have set initially, and if this needs corrections, it can be done at this review time. This is the second page of the device setting report, which shows the smart guard settings, which Dr. Tushar has already explained. The CGM settings, the reminders, the alerts, etc. can be viewed, and then if that required, modified. Now the adherence report, how the user is using the pump, will be shown in this adherence report, and the metrics used are the glucose measurements he is doing, the blood glucose recordings is done per day, the bolus events, the reservoir and set change frequencies, the suspend duration. All these informations can be taken from this report. And then the last one is the logbook report, which will show the blood glucometer readings, the bolus announcements, the meal bolus announcements, as well as the insulin bolus doses being given by the pump, as well as the right side of the report. You also get the total daily dose, the bolus doses, the total carbohydrates entered in a day. So these informations can be obtained from this logbook report. So in short, we know that 780G is not a fully automated mode of insulin delivery. There are some loopholes in the closed loop. But this caregiving report is an important tool to make, which will help us to make right decisions for children using it. And all the clinicians should create their own personal account, as well as the user should also have a personal account, so that he can upload the information onto it, where the provider can download it and help him to have a better blood glucose control. Thank you.
Thank you, Veena. Veena brought up the important point of coefficient of variation, which wasn't spoken about throughout the session. It's the technologic metric of glycemic variability. And to be consistent with a time in range of 70%, the coefficient of variation must be at least less than 36%. And in the current era, as we talk of time in tight range, engineers at Medtronics are deliberating whether the coefficient of variation must vary between 33 to 34.2% to achieve a good time in tight range. So our next speaker is Dr. Santosh Oleti from Bangalore, and he'll highlight some important case scenarios to enhance our learning while working with the hybrid closed loop system.
Thanks, Abhishek. Good evening, and thank you to one and all. It's been a long day for you, and we really appreciate for staying back. So I'll try to be very simple with my experience of managing this. So, so my talk will cover about use of AID in one of the youngest age groups, and the challenges we faced, how we navigated and find the solutions for the problems, and some learning points for the end user, for the clinicians, and for the machine. And I also like to share a small cohort of user experience feedback from our center. So, this is a child currently close to 8 years old, a little boy. He had type 1 diabetes diagnosed from age 5.5 years, was on MDI analog insulins previously. So 1 year post diagnosis, the child's age was 6.5 years. Parents expressed to wish for using 780G. So what they expected, better quality of life and less variability with the glucose management. So we started. We followed all the standard initiation and counseling, what was shown. And this was the 1 month data. And you can see time in range was 66%, which was quite disappointing for the family, for the clinician. And then we looked, our job was to see why we are not able to achieve it. So as you can see, I have highlighted a couple of things. The use of smart guard was quite suboptimal. And the child was also facing a lot of problems with frequent changes of the infusion sets. So then we sat down with them, tried to understand what's not going right here. And it was a learning curve for all of us to learn what's the challenges here. So from the parents' perspective, I think one of the important things was lack of trust on algorithm, on automation, which is not uncommon, among those some of our families. So because of the lack of trust, they were having overindulgence, frequent interference with the hyper and low sugars, and frequently switching into manual modes and switching off smart guards, and resulting in lack of opportunity for the algorithm to learn the data and program optimal delivery of automation. And parents were really annoyed because I think they had problems with patch discharge, skin sensitivity. The child was only little, 6 years old, 6.5 years old, with very small surface area for the patches to keep rotation, and also child had skin sensitivity. So all this really annoyed them, and we also found that they had a lot of unrealistic expectations. In spite of counseling them initially before the patch, before going on to the 780G, and they were almost on the verge of discontinuing the automation. So what we did, we really had to sit down with them, re-educate, make them understand how the algorithm works, share them what is real expectations from the automation, seek their cooperation and patience for a little longer time, and requested them to not to interfere much with the algorithm, and which means they have to unlearn what they learned in the MDI, and took some time to get adjusted to adapt to the AID. And we also addressed the patch problems. So we have to reteach them the insertion technique. There was some problem with the technique because that's why the patch was dislodging frequently, and also gave solutions for the skin problems. So this was the first month, and 3 months, I think the family really took on the advice, and we were able to manage time in range of 82%. And you can also see, because of the better behavior of the parents with user performance, they were able to achieve SmartGuard more than 90% usage, and that's why the results, as you can see. And even after 16 months, this is the recent data, we're still maintaining 82. Although time in range is good, I think we still have work to do on time below range, because up to 4 to 5% we can accept. Here we have a little bit more than that, so we're working on it. And I've just summarized the findings of the chronology of all the 16 months here. As you can see, initially it was 66%, and with the behavior change and better education, we were able to get 82%, and we're still maintaining 82% of time in range. And the other challenge was, this was only little, as previously mentioned, the approval for automated AID 780G is above 7 years, and this child was 6.5 years, but we still took it as a challenge to try on the little child. And initially this child was requiring only 8 or 9 units. You can see that was just about the recommended minimum total daily dose. So that was another challenge we had to. But over the time, I think his requirements gone up. And so these were things I want to write. And also the auto correction, as you can see, previously it was around 18 to 20%, and it's come down to 9%, which means that the family is managing better. And active insulin time, initially it was 3, and as already mentioned, 2 is always gives a better outcomes with the metrics. And coefficient of variation, which was just Dr. Veena was mentioning, so we were able to get it down from 46 to 37%. Still not optimal. And SmartGuard usage was above 90%. And the reservoir change, you can see, initially the child was requiring every second day changing because of the problems with the skin, and now it's almost come to 3 days. So there are a lot of improvements. And the point here is, I think sometimes even though you counsel them, make them understand, you assume they've understood everything, but still challenges happen. Maybe you have to revisit the education again and again. So this is the parents' feedback. I've exactly cut and copy pasted from parents' feedback on this child. So benefits, what they found, has given the flexibility with to eat the food, and they had better night sleeps. I think that's a big point here. For any parents to have a sleep, a peaceful sleep is a big take here. And they also were convinced there was less glucose fluctuations. The challenges, they still, according to the parents' perception, they had to unlearn and relearn the child's body, carb counting, carb ratios to adapt to the pump's algorithm. It took 2 to 3 months for them to understand. And patch, the quickset issues, initially it was coming often. We thought of giving up the pump as BG levels were reaching around 300 to 400 frequently. But over the time, they've learned the better technique of inserting the quickset, and also found the suitable areas. And what they wish is, as of now, we need to change the patch every 3 days. They want a patch which can last longer, and also a longer usage of sensor, and also more economical. And they also feel to expect the algorithm to be more accurate with auto corrections. So that was one child where didn't do well. With re-education, got better. And this is almost a similar age group. This child is a little girl, 6 years, 10 months now, diagnosed with type 1 since age 4, was on Minimed previously, but around 6.3 age, 3 years of age, parents discussed about wishing to start on 780G, and within 2 months later, we agreed and started on the child. So parental expectation was minimize hypos, especially in the night. That was one of the big challenges they were facing while on Minimed 640, and also improve the quality of life for the entire family. And for a clinician, the challenge was again the age group, which was smaller, and small total daily dose. So this is second child we started, but learning from the first child experience, we were a little bit more cautious and counseled more aggressively and intensively, and we did better with this child. And as you can see, the first month data, we were able to achieve around more than 80% time in range. But after 4 months, it dropped down to 71%. So we were looking what's gone not right here. So I'll just summarize this. So first month, the time in range were 80%, and it dropped down to 70%. But rest of the things, there was no huge change except for the coefficient of variation, which got worsened a little bit. But the carb ratio, carb ratios have changed over the time. But rest of the things doesn't look like anything untoward happening here. So we looked into a bit more micro dissection level, and we found there were certain lot of problems were during the postprandial spikes, which we have to again look into the insulin carb ratios and the time gap, and what we thought avoiding the spikes can minimize the lows. And why was the spikes happening? As you can see, the first this is after the Headley. Parents found themselves certain foods will give a very high spike, so it needed a different carb ratios for the certain foods, and which over the time they learned, and we started acting differently for different foods. And what was happening, whenever there was a spike, the auto corrections were followed up, and the child was going little low, as you can see in the next two slides. So this was hypo post auto correction, which was another problem we were trying to sort it out. So this is what parents were saying. It usually about 200 to 250 in the mornings, especially the breakfast, for most foods. Sometimes it works well for rice items. It's not unusual. We see a lot of families, a lot of kids have specific carb ratios for specific foods. So all we did was trying to understand which food requires more insulin. And parents also wanted to know, is there a option for given split bolus in automation, as there is spike every day in the morning? And because what they were doing in the previous pump, they were splitting the bolus, and these spikes were they were finding it was working well for that. But unfortunately, we don't have split bolus in automation. But it's not advisable, but in extreme cases, I think it's we can try this, where we can split the dose, or we can feed the carb as a split into two, and that's what we can call it fake carbs after the meals, and that's what we were trying to see if that works for this child. Despite of all these challenges, this was the feedback from parents. So what they said, we were taking turns in the night to keep track of levels, and hardly were sleeping for 2 hours in a stretch. So that was really, a big thing for parents to sacrifice their sleep every night because they were worried about natural hypoglycemia. But now they are sleeping throughout the night. I think even though we are not achieving all the metrics, but this has helped them a lot with their quality of life, especially for the night times. And previously, they had to go to school to find and check what's happening with the blood sugar, but now they can sit at home and find what's happening with the child. So these two things were quite appreciated from the parents on the AID. Challenges what they're facing, still ongoing incidents of highs and lows. Would prefer a longer duration of sensor, I think, is need for many of the kids. Sensor sometimes lasts for 2 to 3 days and stops without any notification. It does happen with a few kids. Sensor application and removal should be made easy. I think it's very genuine request, and they are looking for some smaller devices than what is available now. And they also found sometimes the corrections happens a bit late. So from these two cases, what I can share here is, some people say technology will replace the clinician. I don't think so. Technology will augment the clinician role. We still have a lot of role, even though the child is on automation. It does definitely improve the quality of life, improves overall target metrics. But the current challenges are mainly around understanding the algorithm. I don't think algorithms got any problem. It's how we use the user behavior towards the algorithm. And the other problems is adhesive sensitivity, frequency in path changes, smart guard usage. I think we need to focus on these things, and I think we'll be able to achieve better outcomes. And I'm sure they're already addressing some of these issues which are all in pipeline. For example, simpler sensor, which is one use disposable, one single unit, doesn't need it doesn't the transmitter is inbuilt, it's just use and throw. And also the uh, insertion quick sets which are lasting for 7 days is in the pipeline as well, which is available in European countries but yet to be available in India. I think having more experience, not only for the end user, for a clinician and the industry, I think it will improve the technology further and helps us further. And next couple of slides, I just share our feedback from a small cohort of patients. We had around 9 people with diabetes on AID, and age of start was anywhere from 6.5 to 30 years, and half of them were below between 6 to 10 years. And the duration of using this 780G, half of them around less than 6 months, and half of them more than 12 months. And the mean TIR is around 76%, which is as per the international expectations. And the time below range is 5.2, which is not great, but we're still working on it. And when we asked how many were satisfied with the decision of using 780, I think 2/3 said yes, and 1/3 still not sure. They said maybe. And when we asked, well, does it meet their expectation, what they imagined before using 780, I think majority said yes, and few of them said no. And the reasons for yes is better quality of life, peaceful nights, less hypos, freedom with food, excellent glycemic control, and proactive management of highs and lows. So the cases which I showed was the most challenging case, but not every case is like challenging. Some of them are they cruise through very easily. And the reasons people said no, it did not meet expectations, I think mostly not with the algorithm. It was more of tapes, CGM tape issues, rashes, sensor not lasting for whole duration. And one of them commented 2 hours, sorry, it should be 2 hours. Long warm-up time was something which they didn't like it. And a few of the other suggestions they shared was to make the sensor application more easy, cost reduction, 2 weeks of sensor life is better, further reduction in the size of the pump, and better CGM tapes. Thank you.
Thank you, Santosh. Thank you for highlighting the aspect of lack of trust that patients have initially. And the 4 common features that we found while analyzing the data was patients would exit to the manual mode themselves when the algorithm did not ask them to do so. This was the first lack of trust feature. Second was an attempt to administer correction boluses by entering fake carbs. This was the second mistake that we found in the Indian cohort. Third was changing the settings to conservative ones by parents with children who were younger than 5 years of age. So they would self change the basal target to 120 when not asked by the clinician and increase the active insulin time. And last but not the least was they would switch the suspend before low feature on. So while the sugar dipped to below 90, the algorithm would switch off the insulin delivery. I think the message is we must convince our patients to trust the algorithm as its efficacy is well validated both in controlled and real world settings. The onus of the clinician is provision of optimal settings and supervising it. The onus of the patient is to adhere to the settings provided and adhere to appropriate user behavior and allow the algorithm time for at least 2 weeks, because the algorithm works on the principle of adaptation, to start demonstrating its efficacy. So I'd now like to invite Dr. Archana Arya for a fireside chat with a patient using the automated insulin delivery system to hear from the horse's mouth as to what the patient feels like while using the system.
Well, good evening, everybody, and thank you for your patience. For those who have stayed on, these kids have been waiting for a while, and it would be nice if everybody interacts with them. I'm sure they're tired of hearing about the pump. They live with it, so they probably know more about it than we do. So I won't waste much time. Yeah, can I know your
Myra.
name? Myra. That's Myra, and that's Arush, right?
Yes.
Yeah, he was sitting next to me, so I asked him his name. So let's start with Myra. Myra, how old are you?
I'm 15.
15. Okay, and how long have you been diabetic?
So I got diagnosed, I think, when I was 2.5 years old.
Oh, okay.
So, yeah, 13 years.
Oh, that's a long time. So you have a lot of experience. And how long have you been on the pump, insulin pump now?
I'm not sure about that, but I think since I
Approximately?
was 6, 7 years old.
6, 7. So you started with the other pump and now you switched over to the 780
Yes,
recently.
yes.
And how long has it been since you switched over?
I think 2 to 3 years.
2 to 3 years. Okay. And how was your control pre-pump and
Um,
on the basic and now on this one? Is there a
So,
difference?
yes, there's definitely been a difference. I think it's made multiple aspects of my life much easier as someone who also plays a lot of sports. Now I don't have to worry about my glucose going low when I'm playing, and it's also helped me in my academics because having roller coaster of a glucose is it impacts your focus as well. So now I think with the new pump, I am living much more easily.
Good. So you think between the earlier pump and this one, it has made a big difference to
Yes,
your
yes,
quality of life,
definitely.
as I can
Yes.
see. And you, what about your sleep pattern? Any change? Any, or were you worried about lows, or were your parents worried about lows? And do
Yes,
they have more peace
my
of mind?
parents were definitely worried about lows. I would hear them talking in the morning that they didn't sleep at all, or they got very less hours of sleep.
Okay.
But now I definitely think that even their life has gotten much
All
easier.
right. And how about your control? I know that's how's your HbA1c been or time in range?
I'm not sure about my HbA1c, but my time in range usually stays around 90%.
Oh, that's great. So you're doing pretty good.
Yeah.
Good. And is there anything else that you think could have been better or something more that you wish for?
I think the issues are majorly same for anyone who's using the pump. First of all, it's the stickers that come with the sensor. Uh, I don't have very sensitive skin, but they cause problems for me too at some point. So I get pimples and rashes.
Okay.
I also think that the size of the pump could be smaller,
Right.
and the warm up time as well, because it usually asks me to change my sensor at night, and then it gets really problematic because we have to keep waiting for the warm up. Then it keeps asking for me to enter glucose, so I'm not able to sleep properly at night when we have to change it.
Oh,
So
okay.
I think lesser warm up time.
True. Well, I think things keep getting better with every model that comes up, and
Yes.
I'm glad that at least the control is good. You've gone through finger sticks probably
Yes,
multiple
yes, I
times a
have.
day, so you've been through all the phases for a long time.
Yeah.
And young man,
Yes, ma'am.
Arush, what about you? How old are you?
Ma'am, I am currently 11 years and I am living with type 1 diabetes since 8 years. And I will be turning 12 at 21st of October. And my favorite hobby is to play cricket.
Cricket. And what game did you play, Myra?
Oh,
You was
basketball.
basketball. Oh, okay. So we have two sports persons here. And so were you also on a different pump earlier, or this is the
Different pump.
first? You were on a different pump. And how do you feel about the change from finger pricks to the basic pump and now to this current pump? Would you like to say something? Tell
Like
me.
in Medtronic 620, I would like it didn't give auto correction, so I had to take insulin directly, which causes hypo. So it gives whereas in 780G it gives a auto correction according to the active insulin.
So you find it easier to deal. And what about your sports? Have you noticed any change in the lows? Has your life changed and from that point of view?
Yes, there were many lows when since I have this pump, but now I am controlling my sugar, so that's why.
Good. So you're doing better. And how's your time in range now?
Ma'am, usually it stays above 95.
Oh, okay. Wow. Wow. So you both are exceeding all the targets. And what are the issues that you face that, like she expressed what she would prefer? What are the changes she would like to see maybe in the next one?
And for instance, in summer times when there was high temperature, the sensor used to got peeled out and it came sensor warm up. So and and the warm up is 2 hours. So for instance, I put the sensor at 10 p.m. and it got activated at 12 a.m.
Okay.
So I have to wake up till 12 a.m.
Okay, so I think both of you face the same issue, I guess, in terms of the warm up time. And would you like to say anything else about how
No,
you
ma'am.
feel after that? Or I'm sure again, parents are happier, I would assume, right?
Yes, ma'am.
Good, good. Would anyone like to ask them any question for their own in the audience? No? Okay. I guess everyone's satisfied with. Would you like to add anything? Either of you, please feel free
No, ma'am.
to say. Myra, what
No,
about
no,
you?
nothing.
Okay, great. So that's great. Somebody has a question for you. Absolutely. Yes.
I want to ask both of you, like you are sports persons. So how do you manage your sports time now with this pump? What do you do?
As the doctor told that there is a temp target, so we set the temp target for 150, and the Medtronic 780 doesn't let go down the sugars from 150.
And how early, before starting session, how long before you set your time target to 150, and how after the session also, like how duration? Tell me the exact duration before starting the session and after ending the session also.
3 hours.
3 hours before,
No, after.
after. And so if your session is for 1 hour, then temp will remain for 4 hours.
Yes.
Okay, and how your sugars are remaining during that time now? It depends on intensity of sports also.
Yes, it depends. I we have to control the sugar also after the lunch. So I go academy for 3 days, Friday, Saturday, and Sunday. So most of the times my sugar is below 150 and above 100.
Okay, so they are in good range.
Yes.
Okay, and do you want to add, Myra, something?
So mostly I play in school. I play basketball in school. I also put the temp target similarly. But if, for instance, I forget, then I make sure to eat something beforehand, maybe 10-20 minutes prior. And then after I'm done, I make sure to calibrate with the prick, with the glucometer, to make sure that it's giving the correct reading. Otherwise, I put the temp target.
Okay, so if you forget both the things, then how your sugar remained? Did you notice anytime?
Um, no, I don't usually forget both at the same time, but I think if it ever happens in the future, then definitely yes, it will go low.
Okay, thank you very much. You're doing great.
Yeah, I think those were very impressive answers. I'm impressed. I think they really need a hand. They're doing so well, and the parents must be relieved. And I'm sure they're doing a great job, better than a lot of adults would do with their management of diabetes and the pump. Very good. We are
Can I?
proud of you, and of course, thank you for being so patient. I know you had to wait a lot, and thanks for being here, and maybe you can go ahead with your meals. Are we
So
done here?
just
We
one
can?
one question.
Oh,
Do
sorry,
you
I
do you
didn't see.
calibrate your sensors?
Sorry, yeah.
Although now with G4 it's optional, but do you still
Yes.
do a calibration sugar, and does it help?
Yes, it helps. If it, I have also a problem with the calibration. Like I enter the calibration by checking the sugar, so it says calibrate after 15 minutes. So that's the problem. But yes, I calibrate. If, for instance, my sensor glucose shows 100, but I am feeling low, so I will check from the glucometer and my sugar is in 70. So firstly I will treat and then calibrate.
And what is your typical TIR that you have? Time in range?
90 to 100%.
Great. Thank you.
Very good. Do any of you want to do medicine? No. Okay, I thought so. They're so knowledgeable. I thought maybe it stimulated an interest in medicine. Well, thank you for being here with us today. Sure. Please. Okay. Absolutely.
Hi, so my feedback for the pump and the accessories is same as what children have said. One more input is that when we see extreme high sugars or extreme low sugars, there is a mismatch between glucometer and pump. That should be addressed. And secondly, obviously, because children are very, in this age, they are conscious. The size of the pump does matter. So it has to be discreet and smaller. Even the sensor need to be of bigger duration. It is 1 week at the moment. And like the doctor mentioned earlier, in 2-3 days time also sometimes it conks off. So it has to be addressed. Thank you.
Thank you.
Thank you. Mr. Kohli, would you like to?
Hi, good evening. More or less, we're satisfied with the pump. I mean, the biggest boon has been no hypos at night. I mean, we've been having to have a peaceful sleep until unless he fiddles a lot with the pump. So, but yes, hypos have disappeared. Honestly, at nighttime hypoglycemia is very, very rare. Besides that, yes, I would request and urge Medtronics to reduce the cost of this technology so that it becomes accessible to more of us. I mean, we need the cost to be cut down.
Absolutely.
Otherwise, trust the algorithm and it does work. Thank you.
To those of who you don't know, Harsh himself is living with type 1 diabetes for many years, and he is doing amazing work educating, motivating, and also pressurizing government for CBSE certificate, etc. He is the one who is deeply involved in all of this.
Thank you, sir. Thank you.
Thank you. Thank you for being here with us and taking out the time. And thank you for your feedback and all the help that you're providing to all the other children with diabetes.
Thank you, ma'am. So to sum up, better glycemic control, lesser glycemic variability, and feedback from patients when we analyzed our retrospective data was better flexibility, quality of life, as Mr. Kohli mentioned. Peaceful night sleeps was the most preferred variable amongst the satisfaction quotient. Better travel and better sports experiences because of the temporary target, and a lot of children closer to the adolescence group did mention particularly better school performance, which may be cognition or better alertness during school hours. And the suggestions which came up from patients while analyzing the Indian data were site reactions. Number one, site reactions. Cannula kinks, especially making a choice between 6 and 9 millimeter. A lot of older children complained about the warm-up time, need for faster adaptation. And while it is said that Guardian Sensor 4 do not require calibrations, Dr. Vinay is here. Our personal experience in the unit is patients who calibrate have a faster or a brisker response of the algorithm when the sugars rise high. So the autocorrections are better when you've calibrated your sensor 4 compared to those who do not. So during higher glycemic excursions, it may make sense to calibrate, even though it's not mandated. The size and duration of use of sensor is always debated upon, and parents often bring it to our notice that the size is large and the sensors must last longer. And in a country like ours where healthcare is sought from the pocket. Last but not the least, the cost of technology. It must be brought down to be made accessible to all. So thank you, ladies and gentlemen, for joining us and being here right till the end.
You would like to add something? Go ahead. Yeah.
Thanks to Dr. Ganesh who told me like to wait 15 minutes before you take the insulin and before the meal, and if the sugar is high you have to wait 30 minutes, and if the sugar is normal like 120 or 130 you have to wait for 15 minutes, and if the sugar is low we have to wait 5 minutes. So this controlled my sugar levels.
So, on behalf of Medtronic, I would like to thank all the faculty and all of you who stayed. I mean, I know it's so delayed, but I hope you enjoyed. This is the technology that has transformed. And to both of you, we are listening, and you will come to know a better, smaller pumps without infusion sets, long lasting sensors soon. So, that's our promise. We are constantly hearing and improvising ourselves. So, thank you again for all
Thank
of you.
you.
I would like to thank all the faculty members, and we close the program. Thank you.